Hi, everybody. Nice to see a lot of old faces. I mean, old friends. My youngest daughter turned 18. Yeah, it's all old faces from here on out. I want to say hi to Dr. Randy James. We were actually lab partners in, was it organic chemistry? Lordy, lordy. It's nice to see him, but also like, oh, I started thinking about organic, huh? Anyway, he's now a physician, and he's and his dad, Dr. James, has been coming out here for years, and now he's practicing. You guys are practicing in Colorado Springs, right? Anyway, so it's really cool to see old friends, and appreciate everybody coming. I actually wasn't supposed to be here. I was supposed to be in Canada, at another conference, but I couldn't make it, I mean, I have something on Monday, so I had to cancel that conference, and then I guess. He who shall rename nameless didn't show up. So you're stuck with me, and I'm sorry I didn't really have something to present. So I've been working on it. I put together something, and I hope it's thematic for what we're talking about here. A couple things before we get started. One is I just want to give you a little history about my father and his interest in vitamin C. And some of you probably heard this already, but he was a psychiatrist. You know, he had nothing to do with oncology, and he had a patient come to him back in the 80s who had, and by the way, it was very nice to hear your patient, because we've seen a lot of non-Hodgkin's lymphoma patients that have responded, as well as renal cell and other things, that they tend to respond dramatically. But his first patient with cancer who he treated with vitamin C was a gentleman by the name of Roger Williams, is that right? No, not Roger Williams. He's the biochemical guy. Okay, anyway, Mr. Williams. I can't remember his first name. But anyway, Mr. Williams came to my father when his office was over on North Hillside, and he had metastatic renal cell carcinoma with metastases to his lungs and to his liver. And as most of you know, that's one type of malignancy that chemotherapy is not effective for at all. At least it's admitted that it's not effective at all for that malignancy. So he had read about Cameron and Pauling and all the work that had been done with vitamin C, and my father was the only one that did intravenous vitamin C in Wichita at the time, or at least he was the only one he could find. And so he said, yeah, I'll go ahead and treat you. And it was just by luck, I guess, that case, by luck or curse, that Mr. Williams, he started out with 15 grams of vitamin C, and then he went up to 25 grams, which was just, a ridiculous amount in those days to give somebody intravenously. And he started responding within a matter of weeks. He began responding, and his tumor started shrinking. And he lived for another he was 70 years old on diagnosis. He lived for another 14 years cancer-free. And so that was his first case. So he was a little bit corrupt. You get a first case like that and puff you up a little bit. But anyway, that case was published in the Journal of Orthomolecular Medicine, I think, also. Another thing I'd like to address is the vitamin C doctor registry. Man, I would get behind that. I don't know about you guys, but the only place I can look, because we have patients all the time that come down to our place in Panama and they want to follow up with somebody, and the only thing that I can find is ACAM. The only thing that's sort of similar is ACAM, but there's so many people in ACAM, many of you may be ACAM members, but there's so many people there that wouldn't be conducive for this sort of thing. So I would really get behind that. If anybody wants to do it, I would be happy to help any way I can to get a doctor. And all over, we have patients from all over the United States and all over the world, and it would be nice if they had a place to go. So. Just a little more history. How many have heard about this? In the news lately, there's been some news reports about Thomas Jefferson University doing clinical trials for intravenous vitamin C. People have heard about that. It was on ABC News and a couple other news outlets. I just want to give you a little backstory, because sometimes that gets lost in as we go forward. And the money for that trial came from the Marcus Foundation. Bernie Marcus is one of the co-founders of Home Depot. And I'm a good friend of his medical director. And I said, hey, you guys, you're sitting there with $4 billion. Maybe you want to spend a little about, just a tiny amount on intravenous vitamin C. And so we were going to do a trial here and they said, well, you need to work with the university, so we went to KU. And ultimately what happened was KU would not indemnify the foundation, and that's all they required to receive the grant. And so they said, is there somewhere else we can go? And Dan Monty at Thomas Jefferson is, he and his, I know several people in his group. So the money actually wound up going to them. But the reason that Bernie Marcus was interested in intravenous vitamin C as a cancer therapeutic and ultimately funded that was because of the work that we did here and the work that others have done. But he was presented a dossier from here, and that's the reason that trial's going on. And the reason they selected those studies is because we gave them patient data, and we said non-Hodgkin's lymphoma, renal cell carcinoma, and pancreatic, although never is there a case of curative, there are many, many cases of increased quality of life and much longer lifespan in pancreatic patients. So those are the three that they chose for the study, but the roots are here in this room. So, when I speak, a lot of conferences, you have to talk about your conflicts. So my conflicts are, I have the Stem Cell Institute in Panama City, Panama, although I'm not going to talk about anything we do there. I have Test Valley Research in Dallas, Texas, which is, we're doing basically developing new drugs from stem cells that we grow in bioreactors. I'm not going to really talk, I'm going to talk about some of that peripherally, but I don't think I have a conflict. I also have Aiden Products, which is a nutritional supplement company, which is exhibiting here, but I'm not going to talk about that either. So I'm potentially conflicted, but hopefully I won't do it. So another company that I founded is Metastem Incorporated, which is, along with the Riordan Clinic, we co-discovered the menstrual mesenchymal stem cell. And that's my only new word today, mesenchymal. Okay, Dr. Levy was giving me a hard time earlier. Where is he? Anyway, I promise, only one new word, mesenchymal. And mesenchymal comes from the mesoderm. We have the endoderm, ectoderm, and the mesoderm. The mesoderm is the middle, and the mesenchymal stem cell is the one that it comes out of the mesoderm. Founder of the Aiden Clinic, which no longer exists, so I'm not conflicted there. And I'm the former director of research here. So my research history, I have 61 articles in Medline. 22 of them, I only put this up, illustration of sort of the ratio. 22 of them are in the stem cell field, and 15 of them are in specifically vitamin C and cancer field. And my two big book chapters are on the stem cell field, and the majority of my patents are in the stem cell field. So I review for several journals. I just want to tell Dr. Mikarova, when you write an article, and it doesn't have my name on it, I know about it. Where is she? So I left here as research director about a year ago, and literally 2 days after I left, I get an article submitted from here by her without my name on it. Anyway, but I said I had to excuse myself as being conflicted. So I'm going to talk about, these are the main points. I probably have too many main points, but one of the themes of our research here at the center was that tumors can behave a lot like non-healing wounds. Also that non-healing wounds can lead to cancer, and I'm going to give some examples of that. I'm going to talk a little bit about the stem cell bank account because it's really important in wound healing. I'm going to show how the stem cell bank can become depleted. Everybody has their own stem cell bank. I'm also going to talk about how nutrients can help, if we're using the banking analogy, can provide high yield dividends back into your account. And I'm also going to talk a little bit about the innate immune system, how that can keep cancer in check, and a little bit about how your stem cells can keep your innate immune system on track. Okay? So a little bit more background about the RECNAC project. It was started for 10 years and we carried over a little bit longer, but it was limited. It was funded by, the Garvey family is the one that funded this place, and they provided a lot of money for research over the years. And the Page family, Bob Page, who was a long-term board member, is the one that provided most of the funds and generated most of the funds for the RECNAC project. And the one thing that he said is, we'll give you the money, but we want everything that you're going to do to be limited to things that are immediately, not necessarily immediately, but in the short term, clinically applicable. We don't want you working on chasing out some mechanism that may lead to another mechanism that may lead to a potential treatment in 20 or 30 years. We're not interested in that. So that kind of limited our scope to nutritional things and also cellular, autologous cellular products. So that it was nice to have that bit of focus along with a lot of latitude within that scope. So one of the natural places for us to look was vitamin C. There were the data from Pauling and Cameron and Jack and Campbell on terminal cancer patients living longer when they took vitamin C than when they didn't. And of course you had the Mertel thing, and Dr. Ron covered all that, so I'm not going to get into the controversy, but I will say that we tested over 60 tumor cell lines, and the majority of them were sensitive to ascorbate in concentrations that were completely non-toxic to normal cells. And the normal cells that we were using were fibroblasts from different tissues. We used colon fibroblasts and lung fibroblasts. So there was what they call selective toxicity. So at this dose, it's toxic to the cancer cells, but at this dose, it's toxic to the normal cells. So we did a lot of screening, and the majority of them are, in the majority of those cases, the vitamin C was selectively toxic, with the exception of every single prostate tumor cell line we tested. There was no toxicity to the cell lines, no cytotoxicity. There was inhibition of growth, a lot of inhibition of growth, but as you got into higher concentrations of ascorbate, what happened was, in order to count the cells, we'd have to trypsinize them. We'd use trypsin, a proteolytic enzyme, to detach them from the flask. Then when the first one that we did, we tried to use trypsin, they wouldn't come off. And so then we wound up using collagenase, the enzyme that dissolves collagen, and after a sustained period of time with the collagenase, they would lift off, and then we were able to count them. So what we hypothesized was happening, and happened many, many times with multiple experience with prostate cancer, and this is part of my dissertation, my PhD dissertation on this very subject, is that they're actually taking the ascorbate and they're using it in the process of making more and more collagen. And so it's interesting to look at cases, and I talk about some of those cases of people who had prostate cancer, and it was intercapsular. It had not spread beyond the prostate, and they were getting vitamin C drips here for years. And their PSA, and Dr. Ron showed some PSAs going up and down, but I mean, we had patients here, their PSA just sort of like steady going up. And 5, 8, 10 years later, they still have a rock hard prostate, and they have an elevated PSA, but they have no extracapsular disease, which in my mind is a pretty good outcome for those people. So I just thought I'd point that out, because prostate cancer, in my experience, is not very sensitive. If you're watching the PSA, I wouldn't count on big reductions in that PSA. But it's a very good idea to keep an optimal level of ascorbate so that they can hydroxylate the protein and produce enough collagen to basically glue themselves in place. That's the way I view it. So one of the questions, there have been a lot of papers out there. There's obviously the clinical papers, and there were a few papers in the literature showing that there was selective toxicity, particularly for melanoma. There was one big paper that they tested 14 different melanoma lines, and certainly it was selectively toxic to that. But nobody had shown, prior to RECNAC, had shown that you could actually achieve blood levels in a human being that were toxic to tumor cells and selectively toxic. So that's what we set out to do. And we had some very helpful volunteers who were willing to sit there and get dose after dose of vitamin C at different concentrations, at different doses. Then we would draw their blood literally as the IV was just ending. We would draw their blood in red top tubes, and then take the serum, and we'd use that in culture. And sure enough, we were getting selective toxicity of tumor cells using the patient's own blood. So we demonstrated for the very first time that you could get blood levels of ascorbate high enough to kill tumor cells in a human being. And with prostate cancer, it was more an inhibitory effect, not so much a cytotoxic effect. So just to set the record straight, because there are many articles that come out and they don't reference our article. There are articles from National Institutes of Health that don't reference our article, Canadian Medical Journal that don't reference our article. University of Kansas, to be frank, doesn't mention our article, even though people from University of Kansas came here and trained and learned about vitamin C, and then basically, you know, okay, I'm bitter, all right? Just a little bit. Little bit. But I would like to set the record straight. So we were the first to demonstrate here at the Riordan Clinic, we were the first to demonstrate that cytotoxic levels of ascorbate could be achieved in human beings. And the U.S. Patent and Trademark Office agreed with us. And they issued us this patent in 1997, which is before most of it. And this was submitted in 1995. So this is the patent, Neil Riordan, Hugh Riordan, Wichita, Kansas, Center for the Improvement of Human Functioning. And basically it's the broadest patent that I've ever received. And it basically says, give a human enough vitamin C to raise their blood level above a level that kills tumor cells, and you got the patent. So anyway, I just wanted to set the record straight. To get over my bitterness. Thank you. Bitterness, gone. So the title of my talk is Tumors Behaving Like Non-Healing Wounds. And one of the seminal articles for me on this was written by Harold Dorchek, and that's how you pronounce his name, by the way. It looks like Dvorak, but it's actually Dorchek. And this was in New England Journal of Medicine in 1985. And the summary of his work is that he looked at tumor stroma and wound healing at various phases, and he found a lot of similarities. And he said, you know, in his paper that the tumors in the body behave very much like wounds. They induce tumor stroma by activating the host wound healing response. And there were talks about this morning, about the inflammatory process that goes on and hijacking the cytokine system. The tumor stroma generation is wound healing gone awry. And Xiaolong and I wrote an article about this very thing. And our suggestion is that it's not necessarily so much that it's gone awry, it's just that it's incomplete. And that potentially completing the healing process could induce remission in certain solid tumors. So how does wound healing take place? So the entire cascade, and I think most of you are familiar with it. I'm not going to bore you with the details, but to me the key player is the MSC, or the mesenchymal stem cell. And from here on out, I'm going to refer to it as MSC. They're found in every single tissue in your body, with the exception of your central nervous system. They're found just outside the central nervous system, and they're obviously very near the central nervous system because they're found on every blood vessel in your body, and the blood-brain barrier, you know, is very integral, very close to the CNS, but they're not found in the CNS. So when this is an important point, when the local tissue is depleted, then they'll be recruited from surrounding tissues. When the surrounding tissue is out, they'll be recruited from distant tissues. When the distant tissues are out, we have to go to, you know, basically we're on plan D, and usually what's recruited are hematopoietic stem cells, which are not very good at wound healing. So there is evidence to suggest that when the distant MSCs from your bone marrow are completely depleted, that cancer develops because it's a last-ditch effort of the body to heal a wound that just will not heal. So the general properties of MSCs that they home to damaged tissue. You know, if you cut yourself, you break a bone, you have a heart attack, you have a stroke, they are going to be, with a cut, you're just going to have localized migration of the MSCs to complete the wound healing. And the more MSCs you have, the more complete wound healing you have. In the utero, there are lots of MSCs. They're not only MSCs in the tissue, they're MSCs floating around in the amniotic fluid. And guess where we can get scarless surgery? It's in utero, right? With the exception of when there are mast cells present in too high amount, then you don't get it. But actually, if you have enough MSCs, they overcome the mast cell degranulation, and you wind up with scarless wound healing. So they secrete trophic factors. That may be a new word, but I'm hoping it's not. Dr. Levy? No? Not a new word. Trophic factors, it's Greek for nutrient. And we use it, there's cytokines, chemokines, growth factors that all fall under this category of trophic factors. And they secrete naked trophic factors just by themselves, single molecules floating around, but they also secrete them packaged inside of they butt off pieces of the membrane called an exosome. They butt off a bigger piece of membrane called a microvesicle, and those also can contain these, they typically do contain these trophic factors. So, and the main effect of the MSCs, but basically the molecules that are secreted by the MSCs are threefold. One is to modulate the immune system. Number two is to stimulate regeneration and repair. And what was the third one? Oh, reduce inflammation. And they're very potent at that. And the last one, this is something new that just came out. They actually will donate their mitochondria to an injured cell, which just about blew my socks off when I read that. And actually there was a paper in Nature Medicine came out about 2 months ago, and I was like, are you kidding me? And then I looked back in the literature, and there are actually 2 other cases, both in renal disease, where the MSCs will donate their mitochondria to the nephrons, suffering nephrons. So this is a total crazy aha moment and paradigm-changing moment in my life when I found out that MSCs can donate their mitochondria, because it changes the entire game, right? Now, they don't need to engraft. They don't even need to hang around. They only need to be there for a day, go, here you go, and I don't care what happens to them after that, right? And so this is the scenario, and I don't have the full reference on here. I was pretty short on time. I can give it to you. Any reference that I have here, I'd be happy to give to you later. But what they did is they took lipopolysaccharide, put it down into the lungs of mice, and it causes a massive inflammatory response, and typically the alveoli will basically die at that point. And rather than in the control group, that's exactly what happened. Then they took MSCs and they instilled the MSCs, and they found not only were the alveolar cells repaired, but the mechanism by which they were repaired, at least one of the mechanisms was that they formed microtubules, which were connexin 43 dependent. It's, that molecule has to be, that ligand had to be there in order for them to latch on. But they would latch on. These microtubules would form just like a little elevator, and they go, here you go. There's your mitochondria. And so they're mitochondria donors, and maybe that's their function. Maybe that's why they're on every blood vessel in our body. They're there to donate their mitochondria when you need them the most. So this is just a cartoon showing that, and there was microtubule donation where there actually weren't any microvesicles formed, where they just would form this channel and dump them in. And then in other cases, there were microvesicles would bud off, and those are much larger than exosomes. They have to be large enough to contain the mitochondria, and then they would fuse with the membrane of the injured cell and then release the mitochondria into the cell. So I've been saying these are everywhere, right? This is a picture from the body exhibit. I don't know how many people went to that, but thank you to the Chinese for doing that deal. That was pretty cool. But anyway, this is a picture of where they had taken a person before he wasn't quite finished. I mean, I think he was finished, but they kept pumping the blood, and they put a rubberized material through his bloodstream, and then they digested everything else away. And so this is just his trunk and part of his arms, his legs, showing the vasculature. So that's where these cells exist. This is a scanning electron micrograph of a blood vessel. Actually, this is a capillary showing MSCs on the outside of the capillary. They're found on every blood vessel in your body. So they're literally everywhere. So I'm going to talk a little bit about aging because it has to do with cancer, doesn't it? Because the incidence of cancer goes up in the 4th, 5th, 6th decade, 7th. And, it's certainly age-related. I mean, there's certain childhood cancers that are exempt from that, but the vast majority of cancers occur with significant aging. And what happens to our MSCs as we age. And this is a little bit deceptive because this is showing, this is the percentage of, essentially the ratio of MSCs that are found in your bone marrow with age, right? And so at newborn, it's 1 in 10,000. Then it's depleted 90% by the time you're a teenager. And you kind of ask yourself, well, why is that? Well, you have to go from a 7-pound baby to, a teenager. So they're used up in that process, right, of development and growth. And so then, basically, from when you're fully grown until you're dead, you got, the last 10% have to last you for that period of time. So that's why it's very important to nourish them properly. So this is, you don't have to read this, it's just a mess. I just copied and pasted the nutrient list that's in alpha MEM, which is a standard, basically a basal type medium that we use to grow stem cells in. So if you don't have one of these in there, they ain't gonna grow. So everything that's listed here, you basically have all the amino acids, you have all the B vitamins, you got vitamin C, you got, what else you got? You got magnesium, you got minerals, you know what I mean? So basically, you got to have everything in there or they won't grow. And that goes to the point of this latest study that was published, that data were demonstrated where you had these growth curves of these rats, and when they were just withheld one nutrient, they didn't thrive, right? So the growth rate was like this for the control animals, and for the animals that were deficient, it was down here. And then when they reintroduced that molecule, they ran back on that same growth rate. That's because their stem cells can't operate. They can't divide and create that new tissue, so they're stuck where they are. Oh, well, I just drew it out for you, but there it is. That was from the latest paper from Dr. Mikaroda and others. So can ascorbate help MSCs grow? This is a paper that demonstrates that yes, they do. In fact, when we grow cells in culture, we add ascorbate, and our cells grow way better than most people because we do add ascorbate. And these are different passage numbers. It's cut off, but this is passage 0, meaning they had just put the cells in the plate. And then this is passage 1, passage 2, and passage 3. And these concentrations over here, this is in micromolar. The 250 micromolar is about equivalent to 400 milligrams per deciliter because that's the world we operate in, right? And so at 400 milligrams per deciliter, you have a substantial enhanced growth rate there. And the next slide is probably more illustrative. This is showing, and the 0 on this, by the way, the 0 on that is not a 0 because we're using basal media, and the basal media have ascorbate in them. Right, so this is additional, and they used in this experiment was ascorbyl 2 palmitate, which is it's an ascorbate, but it's stable in an aqueous solution, whereas if you just put ascorbic acid in there or sodium salt of ascorbate, it's not stable. So this is a stable form of ascorbate that they used, and the top picture there is. This is after 3 days in culture. The top picture on the left is 3 days in culture, and you can see the cells, and they're relatively sparse. It's, maybe 40% confluency. And then at the bottom, that's 3 days supplemented with the basically 400 milligrams per deciliter ascorbate. And then on the right side is after 14 days, and this is basically with the basal medium, and this is supplemented with ascorbate. And which one looks more like complete wound healing to you guys on the right? That's after 14 days. I'd take bottom right over top right any day of the week if I'm trying to heal a wound, right? Well, we talked a little bit about in utero, that's scarless healing. There's another one that most people don't think about is the cornea. You can whack most of your cornea off in 24 hours, it's back, and it looks exactly like it did 24 hours before. Right? What tissue in your body never gets cancer? Cornea, right? It's 2 cases, and it's 2 cases in the history, but there's a debate over where they were actually from the cornea or it moved into there. So anyway, and now there's some new papers coming out showing that adipose in plastic surgery, you can take adipose so these cells are found everywhere, right? Including in our fat. So you can do a liposuction, isolate MSCs from the liposuction, get rid of all the fat, you wind up with what they call the stromal vascular fraction. And you take, and part of those cells, maybe 60% of those cells are MSCs. You take those MSCs and then you inject them below the scar and the scar disappears. So I think the key to real healing is MSCs. So I have a couple examples. These are historical examples, and I was going to say this at the end of my talk, but I'm going to say it now. The great thing about working here was the freedom that we have. We had the freedom, you know, it was within those constructs that I described before, we had the freedom to look wherever we wanted to look, to go, you know, where we wanted to go. And I don't think there's another place in the world that has that. Certainly not in academia. You're going to go where your grant says you're going to go. And you know, in industry, you're going to go where your patents say you can go. And here we didn't have either of those restrictions, and I really am happy about that. And it allowed me and everybody else here to look in a lot of different places so we maybe have a different point of view. So there was one paper that I read, and this was 20 years ago, and it was on, it was a rabbit study, and they took metal plates, and they implanted them intraperitoneal into the abdomen of the rabbits. And they were little tiny plates, but they weren't very big rabbits. And if the plates had no holes in them, so there's no way for basically the tissue to communicate, cancer, they became malignant. The tissue around the plates became malignant every single time. If they punched holes in the plates, then no cancer formed, and basically the wound healed completely. So that really has stuck with me over the years. There's another study, and I can't remember the author. If somebody really wants it, I'll dig around, send me an email, I'll dig around and find it. It's either by Broughton or Houghton. And the reason I know that is because in England, I used to live in the Test Valley, and we had a town named Houghton and a town named Broughton. And when this article came out, it was one of those names. So now you know how I think, not very linearly. But anyway, and she was a female, I know that. Anyway, Broughton or Houghton took mice, and she took basically the bone marrow from another mouse because she wanted to see what happened to these bone marrow cells when she induced cancer in these other mice. So she took the bone marrow out of this group of mice, labeled it, so she knew where that bone marrow came from. And then this other group of mice, she infected them with H. pylori, so they got stomach ulcers, and they weren't treated, and the ulcers continued and continued and continued. And ultimately what happened, this goes back to my statement earlier that you have localized depletion of MSCs, right? There was just a little bit of sideways here. There was a guy who presented at one of our conferences many years ago that showed that there was a localized deficiency of certain nutrients in precancerous lesions, and as long as if you supplemented whatever that was, whatever the most important nutrient was, the one that was out, they wouldn't go on to become cancerous. But anyway, in Houghton-Broughton's case, she showed that what ultimately would happen is you would get adenocarcinoma of the stomach in the animal, and it histologically was exactly the same as all other adenocarcinoma of the stomach of mice that had ever been published. However, when she fished for the DNA for the mouse that was the donor, all of it came from the bone marrow of the donor mouse. I'm getting some funny looks. So these were hematopoietic stem cells that were transplanted from one mouse to another that became cancer in the mouse that had the chronic inflammation. So it was not, they weren't transformed. You know, we hear initiation, you know, promotion, progression, blah, blah, blah. Doesn't make any sense when you look at this, right? This was running out, you're running out of raw materials to fix a problem, and so you go to the bottom of the barrel and you use what you got left, and that's all that's left, hematopoietic stem cells from the bone marrow, because you've depleted all the tissue ones, the local ones, the tissue near it, and the MSCs from the bone marrow have all been depleted. Now, this is all we got left. This is our last one. We're going to die anyway, so let's fire away, right? So that's a very cool study, interesting, paradigm-changing study. There are a couple of studies that show the sort of the flip side of things. If you induce, well, two of them are studies and one's a case report. If you're able to correct the wound healing problem by some mechanism, maybe the cancer will go away. And one was in salamanders, and this was by Rose, and I think Bob Becker, I was actually in the library looking for this earlier. I didn't even get to those books, but Bob Becker wrote about it in one of his books, which would be Cross Currents and the Body Electric. And he talks a lot about salamanders. And salamanders have this capacity to regrow things that we don't. We have actually a higher capacity to regrow our liver than salamanders from a tissue standpoint. But our appendages don't regrow. But a salamander, if you cut off their arm, or their foreleg, or any of their legs and their tail, they'll regrow quite readily. And they form a blastema, and the blastema is comprised mostly of red blood cells. But those red blood cells, unlike us, are nucleated, and most of them have the capacity to de-differentiate into stem cells and then regrow whatever tissue there is. So this Rose did this incredible study where they took, at the time, this was done in the 60s, there were no salamander tumor cell lines. So you couldn't, it was like, well, let's give them a salamander tumor. Well, how? We can't give them a tumor, right? There's no naturally occurring salamander tumors, so they used frog tumors. And they took frog tumors and they implanted them into the forelegs of the animals, and left like that, they would just go on and metastasize and kill the salamander. And then they took where the tumor was and they just chopped off the foreleg, right? And then the blastema formed. The tumor was still there, but they cut through part of the tumor through the foreleg, and so the leg's gone. Now the blastema forms, the leg reforms, the tumor disappears. And then they could fish for those frog cells, and those frog cells had de-differentiated into a cell that could redifferentiate, and they were part of the blood vessels, they were part of the muscle, they were part of the bone. So there are ways, that's like super wound healing, right? So super wound healing took a tumor that was going to kill the animal and turned it into just normal tissue. So I have this is a case, this would be hearsay in court, but this is, I know some of you know Bert Berkson, who's been around for ages, a good friend of the clinics, good friend of mine, was a good friend of my father's. And we spent a lot of time talking about cancer and different things. And his uncle had melanoma, had a big old melanoma, and they lived on a farm. And the doctor said, well, he went to the specialist, and then he went back to the country doctor, and the country doctor said, hell, I'll take care of that. And he took out his neurology wheel, that he used to test for, how somebody's feeling. And he went, punched holes, like 150 holes right through the melanoma on his chest. And the thing got like horribly inflamed and horribly infected and promptly fell off within weeks, right? And then that guy never had melanoma again. And that was, it was big enough, it was wide and deep surgery, and he's probably going to come back kind of thing. Anyway, that's always stuck with me, It stuck with me because, well, it's so graphic, but also, he was inducing an innate immune response that wasn't there. Obviously, the innate immune system was ignoring this cancer, right? And so by really destroying the tissue around it, it alerted, it said, hey, come and get it. And while we're there, hey, let's cart this off too. Thought it was pretty cool. So recently, K-State's done a lot of work with MSCs, particularly from the umbilical cord. And they actually were the first to demonstrate that you could take umbilical cord MSCs and drive them into neurological, basically neurological lineage. But they had a paper come out the other day, and I'll just let you read the title. Not the other day, the other year, a couple years ago, 3 years ago. Everybody got it? So 100 days, they implanted a tumor into into these rats right here, right? And normally that tumor will grow and metastasize and kill the animal. And the only thing that they did differently in some of the animals, they gave them a single dose, either intravenously in the tail vein, or I think it was intraperitoneally, a single dose of not too many MSCs from human umbilical cord, right? And what the title says, I'm sorry?
It says rat umbilical cord?
Rat mammary carcinoma. Oh, okay, sorry, rat umbilical cord. That's even better, because some people would say, hey, it was a human. They've done a lot of studies with humans and rats, so I was confused, but thank you. So they, no evidence of metastases or recurrence 100 days post-tumor cell inoculation. So here are the data points. So yeah, there's oh no, I'm sorry. Intratumorally, IT, they injected the same number of cells either into the tumor or IV. And these are the two graphs of the total tumor volume. And basically the intratumoral kind of had a quicker response, but in the end, you know, in the end, the same result. The result was the same. There was no tumor in either animal. And then where you see the thing going up, the animals were sacrificed because they had so much. The tumor burden was so high. So here's an image of the rat umbilical cord MSCs and the vehicle on the left, and you can see the primary tumor there. And on the right, it's gone. So I don't have a lot of data, and I don't really have a lot of time to talk about it, but MSCs can induce apoptosis, programmed cell death, in tumor cells. And if you have a high enough ratio to MSCs of tumor cells, they will undergo apoptosis, which is the main problem with tumor cells. They home to inflammation. They selectively home to the tumor. There are a lot of studies going on right now using this innate function of MSCs and their ability to home to inflammation and home to tumor cells, to load them up with, you know, smart bombs so that then they can deliver that load to the tumor. But it may be that you don't even need to load them with anything, and that's something that people are also investigating. So I just want to, this is the microenvironment that looking at the histological evidence of using these cells, right? And I don't know if you can read, it's hard to read, but you know, on day 8, there's predominantly, in the PBS, predominantly tumor cells, no inflammatory cells, and the same in the treatment side. On day 14, there's a thin layer of granulation on the PBS side, and there's a thick zone of granulation. So wound healing is better, mo better. Then on day 18, there's a thin zone of granulation tissue, absence of inflammatory predominant cells. And then on the treatment side, there's a thick zone of granulation tissue with a large number of lymphocytes and a few plasma cells and very few tumor cells at that point. And day 100, well, all the rats were gone on day 18, but tumor cells are absent. They're macrophages, and there's a little bit of fibrous tissue. So it was actually a very elegant wound healing, because if it was not inelegant wound healing, you would have a lot of fibrous tissue. So these are the conclusions. The anti-tumor effect may be due to a combined effect of a potent anti-proliferative effect, as well as a pro-apoptotic effect mediated by the naive rat umbilical cord MSCs on these tumor cells that were implanted. Because tumors were completely abolished with no evidence of recurrence, the cancer-initiating stem cell population seems to have been eliminated, and that is a big buzzword these days, is the tumor stem cell, or the initiating cell. So two of these, we're doing a lot of work, basic research on these secreted factors from MSCs, and two of the big dogs that are in there, one is IGF binding protein 3. It's secreted at very high levels by MSCs without manipulation, without genetic changes to them. There's a lot of it secreted, and it's a very, very potent anti-tumor agent through its apoptotic induction ability. And another molecule that's it's found in high concentrations is follistatin. I wanted to call it follistatin, and there were only like 5 articles when I called my friend at University of Utah, and I went, hey man, did you know there's a whole bunch of follistatin in that? And he goes, well, we call it follistatin. So anyway, follistatin is the natural antagonist to myostatin. Myostatin is the hormone that prevents our muscles from growing beyond a certain amount. And as we age, our myostatin actually stays pretty same, but it stays pretty stable. Follistatin, because a lot of it is produced by our MSCs, which are declining with age, tends to decline with age. So it may be a good idea with sarcopenia of aging to resupplement the follistatin that you're missing to counteract the activity of the myostatin, which remains relatively constant throughout life. But it also may be important in cachectic patients who are losing weight, although that's a complex subject and I'm almost out of time. I'll give 2 minutes to innate immunity and then I'm out of here. So Zhang Shankui, any Chinese here? Saying it right? Shankui? No Chinese? Shankui? Is that correct? How do I say it? Okay. Anyway, he's at Wake Forest. And he's published a number of papers on these. He basically bred a strain of rat or mouse that cannot get cancer. You can inject it, you can do whatever you want, and it just rejects it every single time. Then he took the bone marrow from those cells, from those mice, and gave it to other mice, and then try to give them cancer, and they can't get cancer either. So there was a big article in New Science, in some sort of lay science publication. They call it "The Mouse That Roared," right? And this was several years ago. Anyway, Dr. Kui he demonstrated that the effect is from completely innate. There's no acquired immunity whatsoever. These are NK cells, neutrophils, and macrophages that have all the activity in these mice. So his idea was to screen a bunch of donors, right? And Nina did it. We talked about doing a study, and so we got a bunch of healthy volunteers and looked at their innate ability, innate immune system, because he was after, here's another political thing for you real quick. He was trying to get another friend of mine to give him $10 million to do a study to find the donors that were going to have this innate immunity that was going to be high enough to be used in clinical trials. And what we found out here is that basically if you're under 25 and breathing and relatively healthy, you're a good donor. So you don't need to spend the $10 million to screen people. You just get young, healthy donors, and every time their cells work, right? So anyway, there's a clinical trial going on right now, and I know one of the trialists, and there's some good early indications that just transferring innate immune cells from a young, healthy person to a person with malignancy is beneficial. And what Nina found out is that not only with age do you have declining innate immune function and the ability to kill tumor cells, but cancer patients are completely off the chart when it comes to, in a bad way, completely off the chart low for innate immunity against tumor cells relative to even age-matched controls. So one of our early cancer patients here in this facility was a young gal from Arkansas. She had widely metastatic breast cancer. It was open and closed surgery. Basically said nothing we can do. She came here. And at the time we were perfecting our phagocytic index. So that's a number of white blood. Basically, the number of white blood cells, the potential phagocytes, the neutrophils, and the macrophages that would engulf a foreign body. In this case, we're using Baker's yeast that was labeled, right? And then, so that's one part of the test, and another part of the test was how effectively they would kill those Baker's yeast intracellularly. But anyway, our normals were 67 to 77% of the cells. When she got here, it was 1%. 1% of her cells were actually had the ability to phagocytose. And after a series of 5 IVs, she was over 90%. So vitamin C is very important obviously for innate immunity, and just using this as one single example, we know that lymphocytes they hoard vitamin C because they need it for their function, including NK cells. They have like 6 times the vitamin C that's circulating in plasma, and they do that because they need it. So MSCs are also a very big supporter of innate immune cells. Innate immune cells come from your bone marrow. Well, what supports your bone marrow? What supports all of your tissues in your body? Which cells? MSCs, right? They support all the tissues in your body, including your bone marrow. In fact, there have been cases recently in Israel, they have failed bone marrow transplants, and then they give them one single IV dose of MSCs, and guess what? Transplant takes. Because they're tissue support cells, and they're out of tissue support cells, so they just give them one dose, they get better. So, now you guys can read all that. Some tumors are like non-healing wounds. MSCs are wound-healing workhorses of the body. They can be depleted by a number of factors. They can be recharged by a number of factors, including optimal nutrition, and that's what a lot of you guys do. Optimizing nutrition, finding the most important nutrients, and what are those? Yeah, you guys are smart. And IVC can help your patients go back up the curve to a more efficient wound healing through better repair and repair cells and a better innate immunity. Thank you. I already said this, but I really appreciate having been part of the center and being able to research here. Such an exciting environment and a great place to learn, and it helped me to become who I am and to do and more than anything else, it helped me to think the way that I think. And my wife doesn't like that, but it's worked other ways. But anyway, thank you for listening.